ஓகே ஓகே.
Sir David, sir.
Oh, yes, you're running.
Sir, shall we start, sir?
Yes, yeah, no problem.
Yes, sir. I request Dr. V. Pavitra Lochini to deliver the welcome address.
Yeah, thank you, ma'am. Good evening to all. I feel great to begin the second day of Faculty Development Program with the blessings of our Honorable Founder Chancellor Dr. A.C. Shanmugam Sir, our President, Engineer A.C. Arun Kumar Sir, our beloved Secretary Sir Thiru A. Ravi Kumar Sir, our respected Medical Director Dr. Shah Nawaskan Sir. I warmly welcome Mr. David Manuel, a clinical specialist in respiratory chartered physiotherapist and independent prescriber, MSc Advanced Practice in Healthcare NHS United Kingdom, for presenting oxygen therapy. I also cordially welcome our respected principal, Dr. C.V. Senthilnathan Sir, our vice principals, our beloved staff members, students and practitioners of various colleges and practitioners. Once again, I welcome you all. Sorry, ma'am. I welcome you all for this SDP program. Thank you. Sorry.
Good afternoon, sir. On behalf of
Yes,
Faculty of Physiotherapy, Dr.M.G.R. Education and Research Institute, I take the honor and pride to introduce our speaker of the day, Dr. David Manuel. Dr. David Manuel is a well-known person to me. So he graduated from BS College of Physiotherapy and started his career at Madras Medical Mission. He was working there up to 2003 and then he graduated for his clinical studies as MSc Advanced Practice Healthcare in UK. Currently, Sir is working as an independent prescriber in NHS UK. Now, I request our beloved Medical Director, Dr. Shahnawaz Khan, to address the gathering. Sir, MD sir, unmute பண்ணுங்க sir. MD sir.
Yes, sir. Yes, madam.
Yes, sir. Yes,
now
sir.
only now only found the option there. Okay.
Yes,
thank you very much. Request me to moderate this program today. I sincerely thank our Mr. Dr. Senthilnathan has arranged the faculty development program in spite of all the difficulties and Corona-19 problems or everything. And he is the first person is arranging the faculty development program in the whole of our campus. And I'm very happy about it. And also all the people, that is all the faculty members who are all with them, I'm sorry, with him, is helping him to do this program in a face daily. They got the fixed time and doing. Many people are getting benefited. Actually, yesterday program, very wonderful program. Really, I was very happy. I was listening from beginning to the end. It was so nice to listen such a program, and I think today's program also will be very much useful. The oxygen therapy. I am very much interested in oxygen therapy. I will let you know why I am interested. The end of the session, I will give you another picture. Why I am interested in this program. Okay. Thank you very much. I request Honorable the guest speaker to start the program. Thank you very much.
Thank you, sir. Dr. David, please do the honor,
Yes, Your
sir.
Honor.
Yes, sir.
Yeah. Your Honor, can you hear me and see me as well?
Yeah, I can see you, sir. You can start
Is the
your
screen
presentation
clear?
later. Yes, sir. Yes, sir.
Okay, I'm starting my presentation now.
Yes, sir.
Good afternoon, everyone. It's a great privilege to take part in this webinar, and obviously, I'm very, impressed with the huge introduction about myself, and I don't deserve that. And I would like to thank all the faculties who's joining in this webinar. And particularly, I would like to welcome all the students who's watching this program on YouTube. And my special thanks to the principal, Dr. C.V. Senthilnathan, sir. And a special thanks to Dr. Yorani Gobrina, who was very persistent in contacting me. Unfortunately, a couple of dates I couldn't do it, but still she was in touch with me and obviously helped me to present this on my suitable date. So I'm really grateful and thank you very much. So today I am planning to talk about a topic on oxygen therapy. And obviously I did do same topic last week for a different group of professionals in Chennai. So I think this particular topic would be very useful among our healthcare professionals. So what I kindly ask you to do is, if you don't mind, if you could have a paper and also a pen, so that you can take a little. I'm quite happy to share my presentation. At the end of this presentation, there will be a small quiz. It's not for telling me how much you learned. It's a self-reflection, so that it just help you to understand how much you really observed the presentation and how much you're really taking it in. So if you can have a piece of paper and pen, take a small notes. You don't have to write down the whole presentation. And at the end, we will ask you a very simple question as part of the quiz, self-reflection, and then you can answer that and self-reflect on yourself. So let's move on. So my aims and objectives of this presentation is, I would like all the audience, I mean the faculties may have a huge knowledge on this particular topic. Some people may have some knowledge, but may have some areas where they're not clear about it, or people who don't know really about this topic. So this presentation is pitched at all level, so that if you wanted to upgrade your knowledge and skills to understand fully about oxygen therapy, or you don't know anything about oxygen therapy, this is the first time you're listening, this would be an ideal one. I'm hoping it will be an ideal one. So I would like all the audience able to understand oxygen therapy and how to deliver them using different devices. So understand oxygen therapy principles, discuss aim of the oxygen therapy and indications. Very, very importantly, the last one, understand oxygen flow and delivery system. So we all have some idea about why we are giving oxygen to patients, but when it comes to how, which way, there is always some kind of uncertainty going on. So hopefully, at the end of this presentation, we'll have a clear understanding. So to deliver this presentation, I got a number of slides I put together. I don't want to go through one by one because we will be looking at those slides next. So these are my contents, and I'm quite happy to answer all your questions at the end of the presentation. If you have any, it doesn't matter. Don't think that it's going to be a very silly question to ask. Do not assume like that. It could be a very, very useful question for so many people. So please write it down. And if I am very clear about that particular answer, I will be able to help you with your question. Okay, let's start with our presentation. Oxygen therapy principles. Let's refresh and brush our knowledge a little bit about oxygen. Oxygen concentration in room air is 21%. It seems very simple in one line. Let's have a bit more clarity of that particular line. So what is this oxygen concentration in room air in 21%? So we are breathing in from air in our environment, in our home, and we feel okay, we feel comfortable with that. So purely the reason for that, in the room air, we got 21% oxygen. So what rest of the content of the room air is nitrogen, which is majority of them, 78%. And also we got argon and carbon dioxide. So what does this 21% mean to us? To simply explain this, I would like to give an example here. Imagine every time you breathe in, you are taking in 100 ml of air into your lungs. So if you take 100 ml of air into your lungs every time you breathe in, that means you got 21 ml of oxygen in that 100 ml. So the 21 ml in percentage, 21%, we call them a fraction of inspired oxygen, FiO2. We know we don't breathe only 100 ml air because the tidal volume goes with your body weight height. Assume most of the adults will have a tidal volume of 500 ml. So if your tidal volume is 500 ml, approximately, if the FiO2 is 21%, so if you take 21% of that 500 ml, approximately 120 ml in that 500 ml is oxygen, and the rest of the 380 ml is the argon, carbon dioxide, and particularly nitrogen. I hope this will give you a clear idea of what is this oxygen concentration on room air 21% mean to us. So that's all we need. That's all we need is 21% of oxygen to survive healthily, to keep our breathing going without any breathing difficulties. So oxygen has a vital role in management of hypoxemia. Hypoxemia means low oxygen. And when it comes to respiratory failure, there are two types of respiratory failure, type 1 and type 2. This topic is quite tricky because you wanted to concentrate on this topic, but you may end up in going and step into other topics to explain this topic. So, but I don't want to go out of this topic and explain other areas because respiratory failure alone is a huge topic to present, and we take another hour for talk about respiratory failure. But simply explain that we have two types of respiratory failure. One is type 1 respiratory failure, another one is type 2. In type 1, you will have only problem with oxygenation. Your partial pressure of oxygen will be below. We call them hypoxemia. In type 2, there will be two problems. One will be a high carbon dioxide and another will be low oxygen. So the easy way to understand this, type 1, only one problem, low oxygenation. Type 2, two problems, high carbon dioxide and low oxygen. So if I take you into my next slide, you will be able to see some numbers there. The ABG stands for arterial blood gas. And when you analyze them, you got a normal value at the top. PaO2 means partial pressure of carbon dioxide, and PaO2 means partial pressure of oxygen. And you can see two values. One is a kPa, which stands for kilopascalate, and another one is millimeter mercury. You're asking why you got kPa, why you got mercury? Because every hospital has got a different calibrated machine. Some hospital produce your blood gases in kPa, which is kilopascalate. Some hospital will give you blood gas in millimeter mercury. So that's the reason I gave you numbers to understand. If you're used to millimeter mercury, so that's your normal value. If you're used to kilopascalate, it's a normal value. But in my example, in two blue slides at the bottom, all the values are in kilopascalate. So if you look at the first one, which example says type 1 respiratory failure, you can see everything is normal apart from your PaO2, which is your partial pressure of oxygen. So which is represent type 1 respiratory failure. That means the patient is hypoxic. And if you move on to my another example on the little blue slide, type 2 respiratory failure, we got two numbers rearranged. One is partial pressure of carbon dioxide, PaCO2, and also your PO2. In type 2 respiratory failure, as I explained before, you got two problems, high carbon dioxide and low oxygen. Even though the managements are slightly different, but still oxygen therapy plays a huge role in both of these respiratory failure. I hope we understand what is this FiO2 21% mean, and we know now what is type 1 respiratory failure, what is type 2 respiratory failure is. Let's move on to the rest of the presentation. Oxygen is probably the most commonly used drug in the hospital. I don't know how many of us are aware that oxygen is a drug and is a medicine, and it has to be prescribed. Oxygen is a prescription drug and should be prescribed by a prescriber. You could say, oh, I am a very experienced clinical person. Can I handle oxygen? Of course, you can give advice. You can discuss with the doctors about what your expression is, but it does not give you the right to prescribe the medicine. So to prescribe this, everybody has to have a prescriber qualification. So normally, it happens to be a doctor or a consultant who owns that responsibility. So even though we know it's not simple, yet it is the least valued in terms of correct prescription delivery and risk management. So every time you go into the hospital, you pick up drug chart or you pick up the way the patients are receiving oxygen, there is something always wrong. So it has been very well proven in so many studies and in audits. So we'll move on to see what we can do to avoid this and how we can prescribe this oxygen in a correct way. What are we trying to achieve? To maintain the patient oxygen saturation level as close to a normal value as possible, given the patient current disease. So to know somebody how much is their saturation, what we need is a very simple device called the pulse oximetry. I'm hoping most of the people know what is pulse oximetry. If people haven't been to hospital or if they're not exposed to clinical setting, obviously you can see a little picture on the slide, a little finger inside a little monitor. That's called the pulse oximetry. The pulse oximetry gives you two values. One is the saturation, another one is your heart rate. So what is the normal saturation? The normal saturation, for example, people without any respiratory conditions, without any chronic respiratory conditions, if you don't have any lung problem, your saturation is expected to be 95 to 100%. You can put your pulse oximetry, and if you see your pulse oximetry showing 98, do not panic thinking, oh my God, I'm not 100%. It's not. Anything in between 95 to 100 is considered to be normal. But for people with the COPD, I'm just putting that as an example. COPD stands for chronic obstructive pulmonary disease. Once they are diagnosed, we don't know what level of COPD they have, mild, moderate, or severe, or very severe. According to the guidelines, their acceptable normal saturation for them is 88 to 92. This is due to their lung damage caused by smoking or their occupational related hazards and things like that. So this is what we need to be very clear about in our mind. Why I am saying this? For example, if you ended up in treating a COPD patient, and if their normal saturation is 88 to 92, and if you panic and say, oh God, saturation is only 92 or 88, I need to put this patient on oxygen, you're not really achieving anything here. As soon as you stop the oxygen, the level will come back to the same level. So we need to know, to know that, so we need to understand a patient past medical history and their history very, very clearly. There are some scenarios where patients are heavy smokers for 30 to 40 years, 20 to 30 cigarettes a day. They might have not been diagnosed with COPD because they haven't really approached the medical team or doctors to get their diagnosis done, but they could be COPD patients. They could potentially have a low oxygen saturation as a normal saturation for them. Okay, why are we giving oxygen? The main reason we are giving oxygen to prevent tissue hypoxia. So why I am insisting here, we are not giving oxygen to treat the condition, but we are giving oxygen to prevent tissue hypoxia. I'll give you an example here. If somebody comes with pneumonia to casualty or A&E or the hospital, by the time they do a blood test, chest X-ray, to come to a diagnosis, it may take a few hours to know that patient has got pneumonia. But they may be coming with the signs and symptoms of shortness of breath, sputum, cough. When they do observations, they may have a low saturation. So that will give you an idea, patient saturation is low. For example, if their saturation should be 95 to 100, but if they are saturating only 80%, you can see that saturation is significantly low. Even though it takes a couple of hours to start the right treatment, which is antibiotics and things like that due to investigation delay, there shouldn't be any delay in putting the patient on oxygen to prevent tissue hypoxia. If that doesn't happen, imagine if he's saturating only 80%, the same amount of 80% oxygen only will be supplied to the brain, like vital organs, kidneys, and the rest of the organs, even including your myocardium, heart. So what will happen, say example 2 to 3 hours, your whole body will be saturating only with the 80% oxygen, which can have a significant impact and damage later on, even though you started the treatment for pneumonia within 2 to 3 hours. So that is the reason it's important when these assessments are done, these symptoms has to be managed. Of course, the treatment has to be started appropriately, but this is purely to prevent tissue hypoxia. Once you provide the right amount of saturation with oxygen therapy, then obviously the treatment for pneumonia will kick in. Once the pneumonia is starting to get better, you can see patient oxygen level will automatically improve after even stopping the oxygen. That's an example. So to understand, we are giving oxygen to prevent tissue hypoxia and ensure adequate cellular oxygenation. So this is something very important for us to understand. Okay, what is the indication? Again, I put it very clearly in red. Oxygen therapy is not indicated for all these conditions. Oxygen therapy is indicated to prevent hypoxemia in the following condition. For example, your patients could be getting treatment for pneumonia, but if their saturations are already 95 to 100, there is no need for that patient to be on oxygen because the patient has got pneumonia. You start the patient on oxygen only if the saturation drops below normal due to their underlying condition. If their saturation is normal, for example, how many times we go to our doctors in our local area, not necessarily big hospital, with a cough, with a chest infection. How many times your saturation get checked? Not many times. They normally do your temperature, listen to your chest, and they give you antibiotics. Imagine in those are the scenarios that you can assume your saturations are normal, but you got chest infection, but that does not affect your oxygen level. So these are the severe cases. You expect the oxygen saturation to go down. That's the reason when patient comes through A&E or casualty oxygen emergency, they do a vital signs straight away. They check your temperature, check your blood pressure, check your saturation, and they will have a clear idea, okay, all these numbers are normal, let's move on to the rest of the investigation. So if you patients develop hypoxia due to the underlying conditions, then that's an indication for oxygen therapy. Oxygen prescription. Oxygen should be prescribed on a drug chart with a target saturation range unless it's life-threatening emergency. So it's very, very important. If a doctor is looking after me, say I got an infection in my chest, I got a pneumonia, you need to write down in the drug chart, the acceptable saturation for me is 95 to 100, and he's starting me on so many liters of oxygen on what type of device. So that it's written, it's prescribed, so that gives the authority to the healthcare professional to handle those medicine, like devices or oxygen. The prescription need to be based on a current clinical need. As I said, we don't routinely start everybody on oxygen. It all depends on what is their clinical need. What is their diagnosis? Is that affecting their saturation? Yes, there is a clinical need for oxygen therapy. That patient will be started on oxygen therapy. Or it has to be prescribed, or I put it on PRN. PRN means as required. For example, some patient may saturate absolutely normal when they are in bed. As soon as they stand up and go to the toilet or go for physiotherapy or rehabilitation, they develop shortness of breath and their saturation will drop. So in those scenarios, patient can be given oxygen during exercise, so as required. Or sometimes patients may have to go home with the LTOT. LTOT stands for long-term oxygen therapy. There are a lot of patients with chronic lung conditions throughout the world living at home with oxygen, either by cylinder or another device called oxygen concentrator. So basically it's a little device. You plug it in and turn on. It sucks the room air and it accumulates the oxygen from room air, which is the 21%, and it can give up to 1 to 5 liters of oxygen to the patient. So it's called oxygen concentrator. There are a lot of patients living at home with these kind of devices. That's the reason it's called LTOT. Long term means we don't even know when those oxygen will be stopped for them because of their chronic lung condition. Of course, monitoring is essential, because that only will give us either patient is deteriorating or patient is continuing to improve, so that we can manage them appropriately. So what is under monitoring? Very simple monitoring is clinical observation. So basically you see how they are breathing. Is their shortness of breath getting better? Or they feel comfortable? They don't look cyanosed? And importantly, you use your pulse oximetry. If particularly patients are in intensive care unit, they will be connected to the monitors on regular basis. Pretty much they will have ECG connected, pulse oximetry connected, blood pressure connected. But if the hospital patients are in the ward, and obviously you can see the healthcare professional nurses coming and doing these obs on regular basis, either 3-hourly or 2-hourly or 6-hourly, depends on the doctor's instruction. If patients starting to deteriorate, we don't keep going up and up and on oxygen. Then important investigation need to be carried out is arterial blood gases. So basically, it's a skilled procedure. Either it's done by the doctors or even respiratory physiotherapist. There is a little kit available to take blood from the arteries. The very common artery used is the radial artery. So you take a blood from the radial artery and you do an analysis, and it's called arterial blood gas analysis. Of course, you remember my third slide, I put a normal value of the blood gases. That will give us an idea how much his patient is. If the patient is hypoxic, we need to know, is it mild or moderate or severe hypoxia? If the patient is improving, obviously you could see their PO2s have improved. And obviously you will do a blood gas only if patient starting to show some sign of deterioration. Then when you do a blood gas, you will see, oh yeah, they have moved from mild hypoxia to moderate hypoxia. So what do we need to do now? We need to change the management, or we need to understand is something else going on, why the patient is not improving despite of starting antibiotics, despite of starting this. Then, or we may need to do a chest x-ray, or is the patient has got pulmonary embolism. So these are the diagnoses will come in doctor's mind to take it to the next level. So arterial blood gas will give you an idea patients is improving or deteriorating, so that they can escalate the treatment. Okay, so we gave an introduction about oxygen. We know now why patients should be getting oxygen, which patients should not get oxygen. Now we're going to talk about oxygen flow and delivery system. This is the area we all have a little bit of concerns or a little bit of doubt. So I would strongly recommend you and advise you to please concentrate the slides from now on, because this will give you a clear idea what is flow and what is delivery system. Let's talk about oxygen flow. Flow means how many liters of oxygen is coming to the patient. Okay, it's nothing else. Simple as that. To do the flow, what you need is a flow meter. So if you look at the screen on the right hand side of my slide, you will see a little flow meter with a green things to turn left or right. So basically to increase the level or decrease the level. So this is very common flow meter, universally used. You could be asking, David, why only up to 15? Majority of the hospital, universal standard, the flow meters are designed to deliver up to maximum of 15 liters oxygen. I have seen flow meters up to 30 liters, but they are all used in a very, very specialized area and not very frequently. So that's the reason it's important to understand any hospital you walk in, or if you walk into accident and emergency or casualties or a hospital bed area, you will see a flow meter marked up to 15 liters. Okay, if the flow can go from 1 to 5 liters, we can call them low flow oxygen therapy. If it is 6 to 10, it's a medium flow oxygen therapy. If it is 11 to 15 liters, which is the maximum cap, we call them high flow oxygen therapy. This is just, that's all you need to understand about flow. So for example, you walk in, you see somebody on 6 liters oxygen, and you should be able to tell, oh, patient is on medium flow oxygen therapy. Or somebody is on 2 liters, then automatically you should say patient is on low flow oxygen therapy. And also it gives you an idea, somebody is on low flow oxygen therapy, somebody is on high flow oxygen therapy, who is obviously very unwell. You can tell somebody is on high flow oxygen therapy because they need significant amount of oxygen to maintain their saturation. So that patient is very unwell compared to somebody on low flow oxygen therapy. I hope you can understand where I'm coming from. Now we move on to delivery types. The delivery types, how we are going to deliver this flow, which is from 1 to 15 liters, is the delivery types. To give oxygen, we are going to look at 2 different types. One is variable, one is fixed. Okay, if you have a little piece of paper, just write it down. Variables. What is variable? The other name for variable is uncontrolled oxygen delivery system. The name may sound really bad. What is this uncontrolled? Oh, does that mean are we causing any damage to the patient? No, it's not. What is uncontrolled oxygen delivery system means? Variable. You can only tell how many liters of oxygen you are giving it to the patient. For example, say imagine you are looking after the patient. I am coming and asking, oh, hi, how much oxygen the patient is on? If you can able to tell only the liter, which is say 2 liters, and if I ask how many percentage of oxygen the patient is on, you can't tell, because the 2 liters for that particular patient may be able to give, say, 28% oxygen. It may be slightly different for somebody else. The reason for that is we are all built differently. We all have a different lung capacity. We all breathe differently with a different respiratory rate, and particularly if somebody is having infection, they may be in shortness of breath. They may be taking a very, very small, tiny breath, not necessarily big, huge breath or big tidal volume. So this varies, and obviously the percentage of oxygen achieved in the lungs also vary. That's the reason you can only tell patient is on how many liters of oxygen. You can't tell how much percentage of oxygen patient is on. That's called variable oxygen system. But there are other devices called fixed. In that one, you should be able to tell how many liters patient's getting, and also you can tell how many percentage of oxygen patient is getting. Okay, I'm not going to confuse you now with fixed. Let's look at the variable devices, what and all available at the moment in the hospital, and how many percentage patient can achieve approximately, because as I said, it varies, depends on the patient's lung capacity, the way they breathe, it depends on their tidal volume. So let's look at variable devices. So what next 4 slides, what we are going to look at only variable devices. What is the advantage? What we cannot tell. Okay. The recommendation by British Thoracic Society, NICE guidelines, British Lung Foundation, British National Formulary, or Indian National Formulary, you will be able to see this nasal cannula. Very common one. Everybody might have seen this used either in the film or in the hospital or in your work settings. The recommended flow for this is 1 to 6 liters per minute. Okay, I put it very clearly. By giving this oxygen 1 to 6 liter to somebody, you should be able to achieve maximum of 44%, minimum of 24% oxygen. Depends on how many liters you are giving. So, example, if somebody comes with a chest infection, the doctor seen the patient and their saturation is 93. So we know the acceptable saturation for anybody is 95 to 100. So the doctor may say to a nurse, could you start this patient on 2 liters oxygen via nasal cannula? That means the patient is on 2 liters oxygen in order to achieve their normal saturation, which is 95 to 100. Once they started on oxygen, the saturation may slightly starting to go up, and then it will be 98. And then they may leave the patient on 2 liters of oxygen via nasal cannula. Some patients may need a bit more than that, 4 liters, 5 liters, or 6 liters. What is the advantage of this system? It's very comfortable. Obviously, it just sits on the nose. It's very cheap compared to other devices. Importantly, patient can eat and drink and talk, which is the important part of patients then. Imagine you are isolated from your family. You won't have, so it's nice to talk to somebody else, or you can respond to the nurses, or if you have some issues, you can talk to them under the people who's looking after you can understand you clearly. What is the disadvantage? Obviously, decreased FiO2 as the minute ventilating increases. Basically, what they're trying to say is somebody who's on 2 liters oxygen may achieve better saturation. The same liter for somebody, their saturation may not go as good as the other person, because if he's trying to take a bigger breath, he's sucking in all the room air through his nasal cavity, and he can dilute that oxygen, and he may not be able to achieve the same oxygen concentration as somebody else. So that's the reason it's a variable system. It varies from person to person, despite of giving the same amount of oxygen. So this one comes under uncontrolled oxygen therapy. Okay, but very effective, cheap, patient can eat and drink. But what are all the disadvantage? It can dry your nasal cavity. It can easily dislodge. I've seen a number of times the patient nasal cannula moved from their nasal cavity to their cheek. Patients are in deep sleep, they wouldn't even know. Sometimes they may be sitting on the pillow if it's not put in properly. And it can cause nasal irritation and bleed. What very common mistakes I've seen is sometimes the healthcare professional pumped the oxygen too much. They ended up in delivering more than 6 liters, 7 liters, 8 liters via nasal cannula, which is not really advisable, which can cause, I've seen because once you're pumping in a dry oxygen through your nasal cavity, all your soft membrane will starting to dry up, and then it will crack inside. Once they're starting to crack, no nasal cavity at all, highly vascularized, you've got a huge blood supply, then patient starting to pour blood out through the nasal cavity. And it will take a long time to stop the bleeding. So that's the reason it's important to follow the guidelines, not to give anything more than 6 liters. And I would like to insist something here. This recommendation and guidelines purely for adult patients. I'm not talking about pediatrics here, because that's a different level of management. Okay, but the concept is very similar, but the recommendation, the guidelines is not for pediatrics. Okay, let's move on and see the different variable devices. This is called the simple face mask. This is mainly used for medium concentration oxygen. So, which means you're going to deliver oxygen from 6 to 10 liters. The person who is getting this oxygen can achieve oxygen concentration from 35 to 55%. In between this range. Again, you cannot tell exactly how much the patient is, percentage patient is getting. You can only tell how many liters of oxygen you are giving. The advantage is simple to use, available with the earlobes for prone position. The disadvantage, it can be claustrophobic. Sometimes patient hates mask on their face, particularly if they are very anxious, particularly they are in the hospital, they don't like the hospital setting, and somebody coming and putting the mask like that, they wouldn't be comfortable. But not everybody, some people. And obviously, it can interfere with the eating, drinking, and talking. And it can irritate the skin. So, what is very common problem in this particular device? If you try to give anything less than 5 liters, because I have seen myself, patients put on face mask, ended up in getting 1 liter, 2 liters, or 3 liters oxygen, which is not recommended by the guidelines. The reason for that is, if the flow from the oxygen flow is not good enough, which is if it's not going to be more than 5 liters, it's not going to flush out what the patient is breathing out. We all know what we breathe out is carbon dioxide. If the flow is not sufficient enough, the CO2 patient's breathing out won't be flushed out enough, so the patient may end up in breathing in what they are breathing out, which is likely to be carbon dioxide. So that's the reason you have to set the flow minimum from anything above 5. So that's the reason face mask comes under medium concentration category, medium flow. Hope so far it's all clear, but if you do have any doubts, I'm quite happy to explain at the end of the presentation. Another variable device is called a partial rebreathe mask. This is called a mask with a reservoir. You will see them very commonly in emergency or in the ambulance. The mask, face mask, will be attached to a little plastic bag. The aim of this device to give high flow oxygen delivery system. It means 10 to 15 liters in order for patient to achieve maximum oxygen concentration. Why this one particular device is called rebreathe? Let's look at the picture here. You got a mask with a little reservoir bag, and you got a little valve will stop the air you're breathing out to go into the bag. So if you can see a little plastic connection into the bag, so when you start the oxygen will flow from the flow meter into the bag and try to fill the bag as quick as it can. When patient breathe in, the valve from the bag opens up, allow the oxygen to flow from the bag. So when the reason for that is that when the bag is full, good amount of oxygen, which is literally 100% of oxygen is sitting in there, which valve will open and allow the patient to take in a nice fresh oxygen from the bag. When they breathe out, that valve shuts down so that the patient exhaled air, which is carbon dioxide, does not go back into the bag. Instead, there is two little valves on the side. And obviously in this picture, you can see only one valve on the left-hand side. The right side, there is no valve. You can see the lot of dots, which is the exhalation port. That's the way the exhale air, which is whatever patient is breathing out, will leak out through the mask. So that patient can't breathe in what they are breathing out. So normally there should be two valves, one on right-hand side, one on left-hand side. That valves open only when the patient breathes out. When they breathe out, the valve opens and allow the air to go out from the mask into atmosphere. This is particularly called a partial rebreathe mask because only one side the valve is there, the other side the valve is not there. But it doesn't matter because it comes under a variable oxygen concentration, which is high level of oxygen concentration, variable device. You can only tell how many liters patient is getting. You cannot specifically say how much oxygen patient is getting. The advantage, higher level O2 level delivered. The disadvantage, again, the problem is you cannot tell how much percentage of oxygen patient is getting, and then it varies, depends on the fit. If the fitting is not right, quite a significant amount of oxygen can be wasted away. So the mask has to be properly fit, but it doesn't have to be extremely tight where patient cannot tolerate. It has to be in such a way that the area where the mask is sitting nicely sealed. If you look at my next slide, very similar device. The only difference is on the mask, you got two valves sitting. So that means patient cannot physically breathe in what they are breathing out. As soon as they're starting to breathe out, the two valves opens up, allow the air to go out. And when they breathe in, the oxygen flow from the reservoir bag into the patient. And if somebody is on somebody who's require high oxygen concentration, and one of the best way to give oxygen is this device. By this way, that's the reason you will see if patient is on cardiac arrest or respiratory arrest or in emergency, most of the patients will be put on because this device give maximum oxygen concentration. Again, the flow has to be set anything from 10 to 15 liters to fill the bag as quick as you can, and it can deliver oxygen up to 90 to 100% to the patient. The advantage is higher O2 level delivered, and non-rebreathing is not allowed because whatever patient breathe out, it escape from the mask. When patient breathe in, the oxygen flow from the bag. Disadvantage, you can only again tell how many liters you are giving. You can't tell how much percentage you are giving to the patient, but you have to say patient is on maximum oxygen concentration. Okay, what common mistakes I have seen in partial rebreathing mask and non-rebreathing mask is, we know This is designed to give maximum oxygen concentration. So the aim is to fill the bag as quick as you can. That's the reason you set the flow meter to 10 to 15 liters, because that is good amount of, imagine 10 liters or 15 liters of flow from the flow meter is so quite a significant amount of oxygen there coming from the flow meter will be good enough to fill the bag. But what I have seen in is they try to wean the patient off oxygen. So instead of changing the device, they ended up in turning the oxygen low from high flow to medium flow, but they will be using the very similar device. So imagine you drop the oxygen from 10 to 5 liters. That means only 5 liters of oxygen flowing into the bag. It's not going to be quickly inflatable. So what happens is patient will be breathing in, ended up in sucking and finishing all the air, oxygen in the bag. So the bag is not quick enough to supply the next breaths to the patient. So that's the reason the flow has to be minimum 10 to 15 liters in order to fill the bag quickly. So when patient breathe in, all the oxygen can flow from the bag. So very common mistake I've seen, anything flow less than 10 liters is not recommendable. So but means anything less than 10 liter, you're going into a medium flow. That means you have to automatically change the device from non-rebreathing mask to a medium mask. Okay, so now we've seen 4 slides, 4 different variable masks delivery system. What did we understand in this? You can tell only how many liters of oxygen patient is getting. You cannot specifically say how many percentage of oxygen patient is on. You can tell approximately, but not specifically. So next, we are going to look at fixed delivery system. So before we see, we will find out which patients do not require controlled oxygen. Okay, so these devices does not give you a controlled oxygen. We explained why. So these are the conditions where you can use those devices to improve patient saturation. Let's talk about fixed oxygen delivery system. The fixed oxygen delivery system is called Venturi devices. Okay, what is the advantage? You can aim to deliver constant oxygen concentration. For example, if you wanted a patient to get a 24% oxygen, you should be able to give exactly 24% oxygen to a patient. In the next of the few slides, you will be seeing some pictures and you can see what exactly they look like. So one of the problem is the Venturi valves are designed to give maximum of 60% oxygen, not more than that. You could ask, oh, why is that? We got the flow meter. When we can give 90 to 100% oxygen using uncontrolled oxygen, which is the non-rebreathing mask, why can't we do the same thing here? Unfortunately, to give 60% oxygen via Venturi mask, the flow meter has to be set to 15 liters. I hope you remember when I talked about flow meters, most of the hospital, we have a flow meters capped up to 15 liters. So that's the reason the Venturi masks are designed for up to 60%. Increasing flow does not increase the oxygen concentration. I'll talk about that in a minute. What is the advantage? Ideal for patients with the type 2 respiratory failure. Okay, just to refresh your mind, go back to our third slide. I told about type 1 respiratory failure, type 2 respiratory failure. This is perfect for people who is already on type 2 respiratory failure or who's likely to develop type 2 respiratory failure, which is high carbon dioxide with hypoxia. Because what we are aiming to do is we are trying to avoid the further increase in carbon dioxide, which can cause respiratory distress, which can cause respiratory arrest, and then which can lead into cardiac arrest. So we don't want the patient to go into significant respiratory failure. That's the reason we are using this particular device. Deliver prescribed oxygen concentration irrespective of the respiratory rate. No rebreathing allowed. Disadvantage, nothing major, cannot be humidified. When we talk about humidified, the common one we use is a cold water bottled humidification, which we don't practice anymore, which is a very old system. There are hospitals still continuing to practice despite of no evidence. When I talk about humidification, I'll explain a bit more clearly later on in my presentation. At the moment, we will just leave it as it is. Important thing is this cannot be humidified, okay? Okay, let's look at this. So you got devices on fixed oxygen delivery system, very simply color-coded. So if you have a blue valve, it will say 24%. If you have a white, 28. orange 31, yellow 35, red 40, and then green is 60. You can say, oh, how do I know how much oxygen I should set on the flow meter in order the patient to get 24%? You don't have to worry about anything. Every valve, the Venturi valves, will have a prescription printed on them, very clearly saying to give 24% oxygen, you need to set the flow meter to 2 liters. It will be there printed, or you can see a sticker around the valve. Obviously, in my picture, you can see I got a little orange one, or in this picture, if you can see, it says to give 35%, the flow meter has to be set to 10 liters so that patient will achieve 35% oxygen. Going back, so what is the advantage? The advantage of the fixed devices, patients should be able to achieve exactly the oxygen concentration you want them to get. And also, it will give you a clear idea if patients are deteriorating, how much we are escalating. So, for example, if you might have started a patient on 24% Venturi, and if their saturations are not improving, then the next step would be not to go to orange, go to white, because the white is the next level, which gives you 28% oxygen. If the saturation is achieved in 28% oxygen, then that's the concentration patient requires. Then obviously the next step will be escalation will be 31% or 35%. But we need to pause for a minute. Because the devices are available, it doesn't mean that we can go up and up and up. If patients are not improving, we need to understand what is going on with the patient, why the treatment is not working, if there is anything underlying going on, what investigations need to be done. Could be, as I said, ABG need to be done to see what's going on. Chest X-ray will give you an idea, bloods. So these are the investigation will be carried out to understand what to do next. Are we on the right direction? So because the devices are available, it doesn't mean we are doing the right treatment. The devices has to be used appropriately, depends on the patient's requirement. So, but I'm just trying to give you an idea, because simply it's a color coded, very, very less likely to do mistakes. So the nurses or the healthcare professional should be able to tell, okay, the doctor's recommended 24% Venturi. This is the 24% Venturi. It tells very clearly to set the flow meter to 2 liters. So if you look at the next, let's look at how this device works. So I did put an example of 35% Venturi delivery system, which is a fixed oxygen delivery system. The recommendation is to give 10 liters oxygen via the flow meter. From the flow meter, the oxygen goes into the Venturi device. So what is this 10 liters? You have to understand whether it is 1 liter or 10 liter, it's 100% pure oxygen coming from the flow meter. When they go drive into the valve with the specific speed, the way the valve is designed, you can see like a jet. The 21% oxygen on room air literally gushes in and dilute that 100% oxygen. When they come out as 35% oxygen to the patient. Some people may be thinking, come on, does it really work? As I said, as you can see, I am a respiratory specialist and I've been doing this job for 20 years. So we got modalities like oxygen concentrator, assessment devices, O2 concentrator. So I have individually checked these Venturi valves, set the flow meters according to the manufacturer guidelines, and put the analyzer on, and the analyzer was spot on, and what was coming out was exactly as recommended by the manufacturer. So it's important to understand. So these are devices are available. If your institution don't have this facility, or if they are not aware of it, I'm definitely 100% confident every institute will have that. So it's important. The universities or the hospitals should have these equipments. What I want to highlight here, the effective oxygen delivery system should be a universal standard of care and should be made more widely available. This is recommended by WHO. You running?
Yes, sir.
Can you hear me? Any problem with the presentation so far?
No, sir. Just light towards your right side, sir. Slightly towards your.
Uh,
Yeah. Okay. Fine. Fine.
Oh, perfect. Sorry about that. I didn't see my messages. Okay, so I hope you guys understand. So the World Health Organization is recommending no point in our having the oxygen if we don't have the appropriate equipments to deliver the oxygen uh, perfectly or properly to patients. So that's something very, very important. And imagine they are not as expensive compared to the amount of money patients are giving for their healthcare. So these equipments are very, very basic standard of care, and it should be more. Okay, what will happen if we don't have the equipment? For example, if you are having a COPD patient who is very, very sensitive to oxygen, and if you ended up in putting them on, say, medium flow oxygen to pump their oxygen saturation level up, and if their CO2 level goes up, then you're taking their respiratory drive off. We all have a CO2 sensitive drive, but COPD patients will have a hypoxic drive. By giving them ridiculous amount of oxygen, you're taking their respiratory drive off, and slowly they will become very sleepy, and their CO2 level will climb up, and then they will go into respiratory arrest. So when we deal with the patients who's very sensitive to oxygen, they have to be handled appropriately with appropriate devices. Okay, now let's talk about patients who require controlled oxygen. So obviously, your categories comes under chronic obstructive pulmonary disease, exacerbation of cystic fibrosis, patients with neuromuscular disorder, chest wall disorders, and morbidly obese patients, because these patients are high risk of developing carbon dioxide narcosis, which we don't want that to happen. Obviously, we won't be able to tell whether their CO2 is going up or not unless we do arterial blood gas investigation. So the pulse oximetry will tell you only the saturation level. This is the reason I'm telling you, if patients are not improving, we need to try to understand what is their background, what are we trying to achieve, what is their underlying diagnosis, are they heading in the right direction. So monitoring is a very, very key factor. So what common mistake happens? Your COPD patients may be started on either wrong flow, wrong device, or the healthcare professionals thinking, oh, patient saturation is low, I'm going to put the oxygen up. This is the reason this oxygen has to be prescribed. If the doctor say, okay, I'll give you an example. If the doctor says COPD patient, I want the patient to saturate in between 88 and 92. I am going to let the nurse to handle the oxygen from 24% to 48%. He written that very clearly in the prescription chart. Patient might have been started on 24% oxygen, which is the first venturi valve, blue valve. If the saturation is starting to drop, say 86 or 85, so the nurse have got authority or the rights to go to the next level because it's been prescribed by the prescriber, and it's given a very clear guidelines to go up to the next step, which is 28%. That's the reason it's very clearly. All these conditions may initially require oxygen therapy 24% via venturi at 2 liters, and then can go up to 4 liters, which is 28%. If the saturation doesn't go up, despite of putting the patient to 28%, which is recommended by the consultant or a doctor, then the nurse have to do the full observation, or the healthcare professional need to be mindful of what's going on here, why patient saturation is not picked up. Then they need to get the medical team in to reassess the patient, to understand what is going on. Is it anything else happening? Is the antibiotic is not working? Is patient developed something else? Is patient need any other investigation? So that we are heading in the right direction, not putting the patient at risk. We all understand all focus is based on patient care here. So the aim is to give the good quality of care using the evidence-based practice. Okay, so as I mentioned before, I said we don't use cold water humidification. So we got uncontrolled oxygen, but you can give a maximum oxygen concentration. And you got venturi devices, but it does not give more than 60%. Do we have any device which can combine both technology and both oxygen concentration, but also we can humidify the oxygen we are giving to the patient for patient tolerance and benefit? Yes, it is. It's called OptiFlow oxygen therapy, which is going to be my next presentation. Before we go, I would like to highlight something here. A situation where controlled oxygen is not applicable. For example, I said your COPD patient or muscular dystrophy or cystic fibrosis should be put on fixed oxygen delivery system using the different colored devices. But despite of me saying that, if there is a life-threatening situation, I mean cardiac arrest or cardiopulmonary resuscitation, then you should not consider this fixed delivery system. The aim is to give maximum oxygen concentration to prevent your organ damage. So in this scenario, shock, sepsis, major trauma, near drowning, anaphylaxis, pulmonary hemorrhage, carbon monoxide poisoning, patient will be on maximum oxygen concentration using a non-rebreathing because patient is on resuscitation stage. Once the resuscitation is successfully done, patient has been retrieved, then once the blood gas is done, then we can titrate their oxygen to different devices. But if there is a situation like where you shouldn't be thinking about giving a controlled oxygen to patient, the patient should be getting maximum oxygen concentration. So as you all know, the only way we can give maximum oxygen concentration is using the mask with a reservoir bag. So you will see them very commonly used in casualty and accident in emergency or in the ambulance. So my last 10 minutes, 15 minutes presentation is going to be how can we achieve maximum oxygen concentration? It means maximum flow, and also tell exactly how much oxygen patient can get is using a OptiFlow, which is called a nasal eye flow oxygen therapy. I am not going to specifically recommend any particular company here. My close work is with a device manufactured by Fisher & Paykel. They're one of the international manufacturer of these devices. They are based in New Zealand, and they are worldwide. So I have been using a nasal eye flow oxygen therapy for the past 10 years, and I would like to share my experience with you guys. And maybe it's an opportunity for you guys to do a little trial in your work setting. So what this does, OptiFlow is an oxygen delivery system designed by Fisher & Paykel. The word OptiFlow is licensed for Fisher & Paykel, but there are other companies also manufacturing very similar devices, but with a different name. OptiFlow offers the ability to comfortably deliver a complete range of oxygen concentration. When I say complete range, what we are talking about, from anything above 21% to maximum of 100% oxygen concentration, and flows to extend the traditional boundaries of oxygen therapy. When I say flows, what did we talked about nasal eye flow? When we talked about nasal cannula, we said the recommendation is not to go anything more than 6 liters. If you go anything more than 6 liters, patient will have a nasal bleed. But here we are extending the traditional boundaries. That means we are talking about flow through patient nasal cavity of anything above 30 liters per minute. Imagine 30 liters of flow is going to the patient nose into their lungs,